So quick pearls for the ICL surgeries. So it is the patient that walks in my office. The first thing that we do is selecting the right candidate, what Kamal has already talked about. So here, these are the various criteria that we would always emphasize. The first thing is the patient is taken on an AR, the NCT, and then we are looking at the sizing. So what Dr. Sanjay was talking about, choosing the right equipment for both the anterior chamber depth and the wide to wide. So no drops have been put. This is the topographer, status of the cornea. Then you have the eye tracy. Then you have the pentacam, and this is the specular. So this is the part of the routine workup for any ICL patient walking in the clinic. The certain criteria of the anterior chamber depth vis-a-vis the cell count and the age, this has to be respected. So once you've scanned these patients on your OPD tools, so the next thing is, what is important is the intraoperative. So for me, when you load an ICL, it has to be a no-touch technique, because the center of the ICL is the most delicate part of the whole lens system. So it should be no optic touch. You have to either pull or you can slide the cartridge and avoid any undue force while pulling. So this is the sponge which comes with the lens, and this is how through the bottle you're trying to pick up. And I'm not holding with any McPherson, just watch carefully this foam tip, and you've already pushed in viscoelastic inside the cartridge, and with a gentle tap, 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 what you're trying to do is, you're trying both the sides to be enclaved. This is the grasping forceps, the crocodile forceps. Gently just grasp, don't use undue pressure while you're trying to pull. You can tear the lens at times. This is the injector delivery system here. Push in viscoelastic. Once you have threaded the sponge inside, and gradually watch the movement out. And what I'll try to emphasize is that the three holes, right from the leading till the trailing, the three holes have to talk to each other. They have to be in the line. And believe me, while injecting, if they are all in the line, I'll show you, you will never have an ICL going in the reverse manner. So for me, sizing is very important. The initial port size has always to be 3 millimeters. It should neither be bigger nor smaller, because it will never cause shallowing, nor you will have wound assisted kind of a injection of the ICL, which should be avoided. So you need to have a temporal clear corneal incision along with two side ports, which are 1 by 1 millimeter. So two side ports here, very gentle, and this is under topical anesthesia. Put a drop of Paracaine, initial scratch, and you just measure 3 millimeters very carefully. The incision, never overfill. So the choice of the viscoelastic has been debatable, whether you use Heal-On or HPMC. I think left alone, it's your own choice. Whatever you are comfortable, both have certain advantages and disadvantages. I do on HPMC. I don't do hydro implantations because I think it's scary. So very carefully, now just watch as I'm sliding the lens in. There is a hole here, there is a hole here, and there will be a hole here. I'm just monitoring. I don't rush. I'm just allowing the lens enough time to unfold inside. The moment I see the leading unfolded, that gives me a confidence that I can release the rest of the lens. Watch again. So be very gentle. Don't rush. You can just monitor whether it's going in the right direction, and you can twist your wrist. And with that wrist movement, you can always have this kind of configuration where the leading would always unfold in the direction where you want. Now, this is the most crucial step for any kind of ICL surgery, and to prevent that reverse ICL inside the anterior chamber. So very gently let it unfold, don't rush, and once you can see, you can release the lens. You need to push in a little viscoelastic on top of the ICL, And this is the specialized manipulator which has those marks on the surface so that it can grasp the foot plate and gradually push it. So always leading first and then trailing. It's not necessary that you have what is called as the Virion or the Callisto. A simple system would work here. So I have an access to both manual as well as the non-marker system. The viscoelastic wash has to be there, and you have now the central hole there in the center. And I think there has been a paper from Dr. Sanjay Chaudhary where the irrigation port is just at the center, and this can help you aspirate the viscoelastic from the anterior chamber. So the aspiration is sitting on the port and the left hand has the irrigation, and what we are trying to do is gently aspirate the viscoelastic so that you don't have the surprise. The wound stitch very gently. So post-operatively what we are looking at is the vault, and vault is basically the distance between the posterior surface of the ICL and the anterior surface of the lens, ideally 250 to 750. So all the pre-operative workup that Dr. Kamal was talking, and what I'm showing is to achieve this on day one. So low vault can cause cataract, and you have a high vault can cause secondary glaucoma. So most of these nightmares end up having either of these two, and that is what makes us concerned whenever we are doing the pre-operative selection and the sizing of the ICL. So I don't think still you need to worry when you have these the EVO series of the ICL where you have a central hole, and this is how you take these patients on the OCT, calculate out the vault on day one, and anything between 250 to 750 is what makes you satisfied. But at times you can have conditions where you have abnormally high vault, but the pressure day one is normal. Just observe these patients. You actually need not to do anything. You have a high IOP, but the chamber is shallow. You can, if you have a non-toric lens, you can just go inside, take the patient in the OR, and you can flip the lens from 0-180 to vertical. So because as we all know, the ACD horizontally is lesser than vertical. So if you want, you can just simply try this, and with a non-toric ICL, of course. You can have, if you have still a high vault and it's a toric lens, you can do the ICL exchange, and you need to go one size lower. Now, in case you have a low vault, but there is no peripheral touch, if the lens is V4C series, you can just observe these lenses over a serial period. You have a peripheral touch, but you don't have any cataract, you can still observe if you have a V4 series of these, the ICL. If you have an early non-progressive, so what is important is non-progressive. So over series of times you have observed that there is some opacities, but these opacities are not increasing. You can observe if you have a V4C, but if you have a cataract which is progressing, you need to explant or you need to exchange one side up. So my dictum here would be explanting and maybe removing the cataract. For if you have a lens, a toric, which is rotated, I think you need to access the vault. If it's a low vault, you need to at least go one size up to prevent that re-rotation in most of these patients. So I think these are some of these the quick pearls that can help you in troubleshooting. Explantation is a very simple procedure, and I don't think one should be very apprehensive of removing these lenses. So this is just 4 days prior that we had this. So viscoelastic goes in. The markings have been placed here. So again, scratch 3 millimeters, mark. The wound has to be exactly 3 millimeters. No wound assisted delivery here. So watch what I was trying to emphasize, the hole 1. This is the hole 2 in the center. And the third hole is somewhere here. So I'm just trying to see that these all remain in line. Just watch carefully. This is in line with this and this. Never ever you'll have the lens going in the reverse. Push in viscoelastic, first the leading and then the trailing. No optic touch and gently tug in these lenses. Viscoelastic wash. And the wound stitch. So this is how you gently pull, put it there, gently tap, and you're touching with any metallic instrument. Very carefully, crocodile forceps, just grab, and either you can withdraw your left hand or you can withdraw the right hand. So either the cartridge or the lens. This is the point where you need to push in some viscoelastic so there are no air bubbles against the sponge. And this is how. So what I'm trying to show you here is the way the lens goes inside the eye. Just watch carefully. I'm being slow here. So the lens, just watch, it has to go reverse. Now you can slightly manipulate them, just push, because you were slow and the lens didn't unfold. So I was able to manage the lens going in the reverse. One word of caution, never ever try to flip the lens which has unfolded in the wrong manner inside the anterior chamber. So if you have a lens which has landed reverse, don't try to juggle and try to push the lens back, because this is a phakic eye, not an aphakia, where the anterior chamber depth is actually not that great.
In this video, we are showcasing how to explant an ICL, whether the ICL has to be explanted if there is some complicated cataract or if there is any refractive surprise. So the process remains the same.
So this is the explant. Again, the process remains the same. Two side port, viscoelastic goes inside. So here, sodium hyaluronate would be a good choice because it will maintain the integrity of the anterior chamber. The same 3 mm incision is what is required here. And this is the Kuglen hook. And what I'm trying to do is use this hook to move out the lens from its position. This is the MST forceps. Just grasp and see how through the same incision you can withdraw the lens. So I think that point of concern, if your lens goes in the reverse manner, how to explant, it's quite easy. Push in some sodium hyaluronate and use these MST forceps and the lens can be pushed off. So I think thank you very much. And now I have Dr. Krishna Prasad Kudlu, and he is one of the high volume leading phaco-refractive surgeons from the south, and huge volume of expertise in terms of refractive surgery and ICL. So welcome Dr. Kudlu, and let's have some words of wisdom from him.